Respected Dr. Sanjeev, Professor Amaresh, dear colleagues, dear students, ladies and gentlemen, good morning to you all. I thank Professor Amaresh and team CTVS NIMS for inviting me to deliver this lecture. I'm going to talk about disasters in cardiopulmonary bypass. Oh, sorry.
Next to this one.
Okay, this topic takes hours and hours to discuss, but I will give you a brief summary of it. Now, as discussed by my previous speakers, cardiopulmonary bypass is very technical and complex, but accident errors can occur due to faulty equipment or human factors. Unfortunately, heart-lung machines do not have sufficient internal redundancy to compensate for many primary device failures, unlike aviation industry. And the two most important things that can prevent these disasters are competent perfusionists and adherence to checklists. Now, CPB disaster is a potentially life-threatening critical event that can happen during cardiopulmonary bypass. These incidents can be grouped into oxygenator failures or equipment failures or clinical events. I'll take you through these three areas one by one. Now, in order to attain safety, we need to understand the trouble. What are the incident rate in perfusion? It is about 1 in 2,500. Australian and New Zealand College of Perfusionists have been running a voluntary perfusion incident reporting system since 1997. So they are publishing these reports as PERS, Perfusion Incident Reporting Systems. Now, the latest PERS 2 report gives an overview of all the incidents that are reported during cardiopulmonary bypass. Sorry for this busy slide, but it shows what are all the incidents that are reported in PERS 2 report. They are grouped into three categories. Good catch near miss means problem happened, but they could prevent harming patients. The second category is good catch no harm, means no harm actually happened to the patient. And third category, which is interesting and important, is harmful events that happen during cardiopulmonary bypass. So 97% are good catch incidents, whereas 3% are harmful incidents that happen during cardiopulmonary bypass. And like I said earlier, human factors are very, very important because cardiopulmonary bypass machine is run by a competent perfusionist. And two main factors that are responsible for these are communication problems and poor teamwork. In order to have safe outcomes for your patients, we should have a good team with a closed loop communication, meaning everybody in the team should be on the same page. They should understand everything in detail about the patient. Now, I prepare this mind map to tell you what are all the emergency scenarios we may experience during CPB and what do we aim for. In these emergency scenarios, we do a lot of steps. To manage these emergency scenarios. These emergency scenarios will include airlock, air embolism, iatrogenic aortic dissection, chamber distension, IVC tear, protein reaction, pump failure, and persistent ventricular fibrillation post-aortic cross clamp removal. Of the lot, I would say iatrogenic aortic dissection, IVC tear are two very disastrous complications that can happen. Now, when you are going to tackle these emergency situations, you need to understand what steps you need to do to achieve a certain goal. For example, during times of airlock, our aim is to flush out air with fluid. Now, during air embolism, our aim is to establish retrograde cerebral perfusion, again to flush air out of cerebral circulation. In cases of iatrogenic aortic dissection or IVC tear, our aim is to achieve circ arrest to facilitate repair of those tears or issues. Now, there are certain general rules we need to follow during the disaster times. First and foremost thing, like I always said earlier also, is that the team is very, very important. Whenever you experience an emergency scenario in the theater, first announce that we have an emergency scenario at hand. So all your team will be on board. they will come for your rescue. Be it a perfusionist, be it another surgeon, they will come for your rescue. Now, we have to understand what stage we are in. Basically, cardiopulmonary bypass is basically bypassing the heart function and bypassing the lung function. Now, we have a situation at our hand which is preventing us from doing that. Now, what do we do to get over that? In the meantime, can we do something else? For example, you have situation. You have an emergency in the theater. You have a disaster and cardiopulmonary bypass. Can you restart heart? Can you restart lungs by ventilation? Or do you have any structural defect that is preventing you from doing that? Now, you have to think, are we closer to restarting the heart function? Are we closer to restarting the lung function? Or are we closer to fixing the trouble so that we go back on full cardiopulmonary bypass to continue with our operation? So these are all things you have to bear in your mind when you are going to tackle these emergency scenarios. Now, you need to inform your anesthetist so that any other drugs that can help the patient can be given. Now, I will go one by one. Oxygenator failures. Usually, surgeons say, blood is dark in arterial line. This is the first thing surgeons notice whenever there is an oxygenator failure, which is nowadays very rare. But the usual causes are gas supply issues. There will be alarm of low gas pressure. We need to tackle that part. And the membrane oxygenator failures are very, very rare nowadays. Now, there is a thing called progressive oxygenator failure. For example, you are doing a major surgery and your bypass times are exceeding 5 hours. So obviously, your oxygenator is going to fail. Then you have to replace it with a new oxygenator. The other thing is that sometimes when you fail to achieve adequate systemic anticoagulation, you may have fibrin clot depositions which will block off the reservoirs, and you again will have oxygenator failures. Now, Dr. Vikas has nicely said about the venous cannula problems and arterial cannula problems. The other important issue we commonly notice in cardiopulmonary bypass is airlock, venous airlock. So, what are the causes for venous airlock? It is usually because of entrainment of air around the venous cannula. Sometimes, even if you snare the SVC and IVC, you still perfusion says air is coming. That is one of the reasons is the bursting may be loose, or the incision you make in the SVC and the IVC to insert cannulas may become bigger. So you have to tackle that. Sometimes the cannulas may accidentally come out of the heart, exposed to the atmosphere, sucking the air again. Sometimes if there is injury to the IVC or right atrium, air can be sucked. If in cases of ASD and VSD, if you have the left heart open, you can have venous airlock. Now, airlock management is very simple. Like I said earlier, our aim is to stop the pump first, flush out air with fluid. If it is too much airlock, then you disconnect, backfill saline into the venous line, again go back and bypass. Equipment failures, these are really bad. Suppose you are on bypass, your heart lung machine stops working. What do? Perfusionist has to use hand cranks to run the pump. So ideally, we should have a spare machine available for all equipment that we use in cardiothoracic operation theatre. It is recommended that if you have 2 theatres, you should have 3 heart lung machines, something like that has to be managed. Unfortunately, due to various constraints of management or in private setups, it is difficult to have that. Then you should have a competent perfusionist to deal with these things. Now, circuit disruption is the most commonly reported incident in PAS 2 report. As you know, Dr. Naresh discussed nicely about the different components of the circuit. They are all connected with cable ties. Whenever there is high pressure, they may break open. Now, I said proper communication is very, very important. Sometimes sisters or sometimes surgeons themselves, we ourselves will clamp the cannula, clamp the arterial line or venous line without informing the perfusionist. So that has a lot of issues. Sometimes the circuit may break open. So communication is the key. You have to communicate to the perfusionist whenever you are trying to do some clamping business among the arterial and venous lines. Now, the other very, very important and disastrous complication we can have is air embolism. It is the third most commonly reported incident in PS2 report. There are three categories of air: surgical air, pump air, and anesthetic air. Anesthetic air is nowadays very, very rare. Usually that is because of loose connections and CVP lines and all those things. But then, pump air basically means air is pumped from cardiopulmonary bypass machine into the patient. It is usually when the perfusionist is inattentive to the reservoir levels. Reservoir can get emptied, pushing air into the patient. Very disastrous complication, but nowadays it's very rare because there are bubble sensor and level sensors are available on newer heart-lung machines. Now, vacuum-assisted venous drainage sometimes can cause this. It will retrogradely push air through the venous cannula into the patient. It's a very bad scenario. I have seen once this complication. It's really bad. And sometimes when the reverse tubing in roller pump or reverse roller pump direction also can give rise to pump air. Now, surgical air, the most common cause is inadequate de-airing. So, you have to strictly adhere to the de-airing protocols. Head down, inflate the lungs, all sorts of things. This is beyond, it itself is a big subject, so I will not go into details of those things. But then, you have to do a proper de-airing to avoid this massive air embolism. And what are the factors that you consider before going on retrograde cerebral perfusion? If air is freely coming from the aorta, or on toe you can see air in the aorta or air in the coronaries. If there is a rapid fall in cerebral oximetry, and if we ourselves are seeing that the air is there, then we must consider going on retrograde cerebral perfusion. Now, this is very, very important. These steps are very critical whenever you experience massive air embolism. Stop bypass, clamp lines and alert team, place head down, give 100% oxygen and set heater cooler to 20 degrees in preparation to go on hypothermic cardiopulmonary bypass. Suction on vents once the correct position of the vent is confirmed. Use air volume to guide your treatment. For example, if the air volume that is gone into the patient is less than 20 ml, probably you will get away by aspirating air from the heart and aorta restart bypass with initial carotid compressions. For example, if the air volume is more than 20 ml, probably you have to go and do a retrograde cerebral perfusion. Retrograde cerebral perfusion was introduced by Dr. Newell Mills in 1980s. As cardiac surgeons, we all should be aware of these steps to perform retrograde cerebral perfusion. You have to stop cardiopulmonary bypass when you experience massive air embolism. Remove aortic cannula and cannulate superior vena cava above azygous vein, snare or clamp below. Check arterial line free of air. Fill it with saline if required. Now, you perfuse 1 to 2 liters per minute for a CVP of 20 to 25 millimeters of mercury for 1 to 3 minutes. This is for retrograde cerebral perfusion. When your aortic opening looks free of air, then you start intermittent carotid artery occlusions for a total of 2 minutes to flush vertebral arterial system. Then you go back on, recannulate the aorta, re-establish hypothermic bypass at 25 degrees centigrade for 45 minutes. That includes giving 100% oxygen, hypothermia, hemodiazation to 25% hematocrit, higher flows, and a moderate hypertension of 70 millimeters of mercury. The additional measures that we all know are giving anticonvulsant therapy, and sometimes we have to know about neurological deficits only if you wake the patient up after surgery. If a patient has got neurological deficits, then with a massive air on brain CT, then probably you have to go for hyperbaric oxygen therapy, hyperbaric therapy, giving 6 atmospheric of hyperbaric oxygen for 48 hours. So in summary, when you have air in arterial side of the pump circuit, off bypass, identify source of air, remove air either by aspiration or connect the arterial line to the venous cannula to commence retrograde cerebral perfusion. Check for bubbles from the aortic root vent. Trendelenburg position, dexamethasone, cold packs for the head. Commence antegrade cerebral perfusion. All of us should be aware of these things. Electrical failure, you should have uninterrupted power supply, UPS systems should be online, and battery systems should be charged and ready for heart-lung machines. Now, clinical events, these are all the events I am going to describe in detail, one by one. Drug and medication error, this is the second highest number of incidents, perfusion incidents reported in PAIRS 2 report. Commonest we come across is heparin resistance. Failure to achieve ACT goal of more than 400 in spite of heparin doses of up to 600 international units per kg. Recommended is to give antithrombin 3, but we normally give fresh frozen plasma 500 ml, that is 2 units of fresh frozen plasma. 1 ml of plasma contains 1 unit of antithrombin. So 500 ml of fresh frozen plasma means giving 500 units of antithrombin to the patient. Usually it helps to achieve target ACT. Still then, if you are not able to achieve, then you have to go for direct thrombin inhibitors like baliverdin or ergotroban. Now comes the devil, protein reaction, HARO classification. Type 1 protein reaction is the simplest of all the reactions. It is histamine mediated. It is usually happens due to rapid administration of protein, leads to vasodilation and decreased blood pressure, usually tackled by giving infusion of volumes and calcium. Type 2 reaction is basically immunoglobulin mediated, usually due to previous exposure to immunoglobulin, insulin and shellfish allergy. It leads to vasodilatation and reduced blood pressure. Treatment involves giving adrenaline, corticosteroids, oxygen and antihistamine. Type 3 protein reaction is the most serious of all. It is usually due to complement-mediated activation of thromboxane A2. There is usually genetic predisposition for the patients to develop type 3 protein reaction. It leads to severe pulmonary vasoconstriction resulting in acute right ventricular failure, or RV will bulge like anything. And most of the times, you have to go back and bypass. Giving heparin, go back and bypass. You treat it with milrinone and NTG, but fingers crossed, hopefully patient will be able to come out of that. It takes a lot of time to deal with this type 3 protein reaction. Cold agglutination is not well known here in India, but in West it is quite common. These are IgM autoantibodies active at lower temperatures. They are inert at physiological temperatures. Whenever you see intravascular thrombosis while you are on pump with hemolysis, you suspect cold agglutination. Management involves avoiding this in the first place and run normothermic cardiopulmonary bypass, avoid cold blood cardioplegia, and you have to give warm shot before coming off cross clamp to flush the coronaries. Malignant hypothermia, again, is a very serious condition. It is hereditary and transmitted in an autosomal dominant pattern. It is usually due to reaction to a specific triggering agents in patients with myopathies, typically affecting the type 1 ryanodine receptors. The signs of malignant hyperthermia crisis are, as surgeons, we can feel heavy rigidity of the chest wall and hyperthermia warm. You can have warm, though your patient perfusion is trying to cool, the patient remains very warm, and then there will be metabolic acidosis, excessive temperature despite cooling, and hematuria. How do you treat that? You avoid all triggering agents such as succinylcholine and volatile anesthetic agents, flush anesthesia machine with oxygen and remove vaporizer from heart-lung machine. The ventilator circuit, CO2 canister have to be replaced, use dantrolene. The surgical procedure should be abandoned as soon as possible. Vasoplesic shock, all of us must have experienced at one stage or the other vasoplesic shock. This is basically severe systemic vasoconstriction refractory to any kind of treatment. The usual causes are due to systemic inflammatory response, sometimes as a reaction to common anesthetic agents with a certain class of drugs like AC inhibitors, ARBs, or ARNIs. That's the reason why we always advise to stop these class of drugs at least 3 to 5 days before we plan for surgery. There will be inability to achieve adequate end-organ perfusion due to hypotension, and it is impossible to separate from cardiopulmonary bypass if not adequately treated. Now, the treatment involves giving vasopressors such as norepinephrine vasopressin, intravenous methylene blue, and vitamin B12. Iatrogenic aortic dissection. Approach early high aortic line pressure as dissection until proven otherwise. The rate of incidence is 1 in 1,000 cases. It's more in femoral access and retrograde aortic perfusion than central cannulation. Transesophageal echocardiography helps in the diagnosis and assessing the extent and in planning the management of these patients. What are the signs of aortic dissection? High line pressure, there will be bulging, tense, bluish hematoma, you can see on the ascending aorta. Sometimes if it is serious enough, you will see a boggy swelling coming from behind the heart. And there on toe, you can see false lumen. And the thickening of the aortic valve will be more than 15 millimeters. There will be bleeding from aortic needle holes, dampened radial artery waveform, systemic hypotension, reduced perfusion, and facial perfusion asymmetry can be observed by the anesthetist. Usually cerebral oximetry desaturation will be noticed. There will be AR and myocardial ischemia and hypoperfusion and acidosis. These are all the signs. The management plan, again, stop the bypass, confirm the diagnosis, and plan your cannulation strategy. Usually go to femoral cannula or axillary artery cannulation, or under toe guidance, put a wire into the true lumen and cannulate the true lumen, then go back and bypass. Because when you have an aortic dissection, the perfusionist cries because there will not be any returns to the pump. But you maintain low pressures, continue giving volume through the venous line when pump is stopped. In the meantime, you plan all these things because you have to cool the patient to go for circulatory arrest to repair. The treatment involves either Bentols or total arch replacement depending upon the extent of dissection. Now the prevention, how do we prevent these aortic dissections? Site selection is very crucial. You should be careful in high risk patients. When you try to cannulate the ascending aorta, make sure the anesthetist keeps blood pressure around 90 to 100, not more than that. And you need to confirm aortic line punctuality before bypass. The perfusionist says good swing. And then infuse small volumes before going on full bypass. You need to be very gentle in cross clamp manipulations or side biting clamp at low flows. IVC tear, fortunate or unfortunate, I have seen only once in my life IVC tear. We were working in a big team where one of my colleagues had this while doing a mitral valve replacement. So the enthusiastic excessive pull of the Cooley's clamp may sometimes result in IVC tear. It is really bad. There won't be any returns. Field is all flooded with dark blood. Perfusionist starts crying. So the management is that, again, come off bypass. Try to push venous cannula to reach beyond the tear. Cool down to circulatory arrest temperature. Repair under circulatory arrest. If the tear is going too much down into the abdomen, then you may need the help of a GI surgeon to correct that. Chamber distension, this was discussed by Dr. Vikas. I will not go into details. Now, this is one problem sometimes we may notice, especially following an aortic valve replacement. Persistent ventricular fibrillation post cross clamp removal. The causes are usually myocardial ischemia due to various reasons, intramyocardial coronary gas. There may be graft problems. Surgical problems are usually because of aortic valve obstructing the coronary ostia and injury to the circumflex artery during a mitral valve repair or replacement. Sometimes if you forget clamp on the previous mammary artery graft during redos, you will have these kind of things. Now treatment involves DC cardioversion. This is again important. You should limit to only 6 shocks, not more than that. Multiple shocks lower VF threshold and can damage myocardium. Use 5 to 10 joules asynchronous with internal paddles. Use 200 joules with external paddles and inflate lungs to reduce impedance. Now what our anesthetist usually calls is a cocktail. You give a mix of lignocaine, amiodarone, magnesium sulfate, potassium chloride and esmolol. Sometimes it works. Of course, if you have any surgical problem, you need to fix that. Like for example, your aortic valve is blocking the coronaries or the mitral valve injuring the circumflex artery, you have to correct those things. Now I have a few questions for the trainees. How many of you have hands-on experience in assembling CPB circuit, and how many of you did rotation in perfusion? Can blindness occur after cardiac bypass run in an otherwise healthy patient? Just some thoughts for your mind. These are the resources I have taken my talk from. Thank you very much.
Thank you, Dr. Rajashekar sir, for that